Imagine preparing to give birth, and 92% of the medical professionals you talk to just cannot give you adequate information about how your chronic condition is going to affect your delivery.
Yeah, that is a terrifying statistic.
It really is. I mean, welcome to the deep dive. Today, we are focusing entirely on you, the listener, and we're unpacking a highly specific and honestly a very anxiety-inducing question. Does childbirth worsen vulvar lichen sclerosus or VLS?
Right, and we have a really massive stack of robust medical literature in front of us today to finally get to the bottom of this.
We do. We are looking at the 2018 British Association of Dermatologists guidelines, so the BAD guidelines, as well as the 2023 BSHH guidelines, some clinical insights from the Women's Health Clinic, and a really interesting review of 33 pregnancies by Nguyen and colleagues from 2018.
And of course, that groundbreaking recent survey by Schaffer and colleagues from 2023, which covered 206 pregnancies.
Exactly. It's a very compelling stack of data.
It is, particularly because, this specific intersection of VLS and pregnancy, it has historically been just a massive blind spot in medical literature.
Yeah, totally ignored, which is why our mission today is to take all this data and separate the fear-based myths from the actual evidence-based reality.
Right, regarding pregnancy, delivery, and postpartum life with LS.
We want to empower you with clear, actionable knowledge because, like I said, those statistics right out of the gate are staggering. Let's just return to that number I mentioned at the top.
The 92%.
Yes. According to the Schaffer study, 92% of pregnant patients with VLS report getting inadequate information about delivery from their healthcare providers.
Which is just, it's unacceptable.
It really is.
Yeah.
And as a direct consequence of that medical silence, 50% experience severe delivery-related anxiety. So, okay, let's unpack this.
Absolutely.
If you are in that 50%, this deep dive is the ultimate antidote to that lack of information.
Well, and that anxiety is entirely rational, right? When you look at the physical reality of the condition.
Right, because you're dealing with a chronic inflammatory skin condition.
Exactly. Characterized by fragile tissue, severe itching, potential scarring. And all of this is in the exact anatomical area required for a baby to exit the body.
The math just seems like it equals disaster.
It does. The internal calculus naturally points toward disaster. But the medical literature actually reveals a profoundly different biological story.
Yeah, let's dig into that, because before we even look at the delivery room, the 9 months leading up to it present this massive paradox.
They really do.
The baseline assumption for most patients is that the immense physical stress of, growing a human would automatically trigger an aggressive LS flare.
Right, because stress usually equals a flare.
Exactly. Yet the BID guidelines, the BSH guidelines, and the clinical data say the exact opposite actually happens.
Yeah, the clinical data strongly supports that pregnancy is often a period when VLS symptoms actively retreat.
Which is wild.
It is. The 2023 Schaffer study surveyed this specific phenomenon, and they found that 44% of participants saw a documented decrease in their symptoms during pregnancy.
44%.
Yeah, while another 36% maintained stability with basically no change at all.
Wow.
So for 80% of these patients, the condition is either stable or noticeably improving.
Which just feels completely counterintuitive when you are used to the daily grind of managing LS. Let's talk about the why there. What are the mechanisms driving that?
Well, we know VLS symptoms, so the severe itch, the hyperinflammation, they are notoriously aggressive in low estrogen states.
Right.
That really explains the demographic peaks in diagnosis, right? Like before puberty and after menopause.
Okay, so during pregnancy, the body is basically flooded with an unprecedented surge of estrogen and progesterone.
Exactly. That hormonal surge essentially remodels the local tissue environment. Estrogen has this really profound regulatory effect on the health, elasticity, and immune function of vulvar tissue.
So it's changing things at a cellular level.
Yes, at a cellular level, these hormones help suppress the specific autoimmune pathways that are responsible for the localized inflammation in VLS.
Okay.
The body is systematically prioritizing the retention and growth of the fetus, which often involves a temporary downregulation of certain autoimmune responses.
So, the pregnancy hormone surge essentially acts as a biological pause button.
Okay, way to put it.
It just floods the local receptors, buffers the tissue, and forces the autoimmune inflammation to stand down. But Let me push back on those Schaffer numbers for a minute.
Sure.
Because if 44% improve and 36% stay stable, we still have 20% of patients unaccounted for.
We do.
This clearly means some individuals still really suffer through their pregnancy. Does parity, whether a patient is parous or nulliparous, basically, if they've had kids before, does that change those odds?
What's fascinating here is that we really have to look at the difference between the immediate hormonal shield of a current pregnancy and the long-term systemic changes of having had children.
Okay, break that down for me.
Well, the 20% who continue to experience flares, they really highlight the fact that pregnancy is not a cure. It's a temporary, highly variable shift in the body's chemical environment.
Right.
And when we look at long-term data regarding parity, the risk factors for developing LS are actually slightly higher in parous women compared to nulliparous women.
So having had children actually slightly increases the long-term risk.
Yes.
So the temporary biological shield of pregnancy definitely doesn't offer permanent immunity.
Not at all.
And that temporary shield actually creates a really dangerous secondary problem, doesn't it?
It absolutely does.
Because the symptoms often vanish during those 9 months, patients get lulled into this false sense of security.
Yeah, and that immediate relief leads to a critical choice they make well before childbirth. They abandon their maintenance medication entirely.
Which is huge.
This is arguably the most critical vulnerability identified in our sources today. The Schaffer study found an alarming statistic regarding compliance.
I know the one you're talking about.
Only 39% of patients use their topical corticosteroids during their pregnancy.
39%.
Yeah, that means over 60% of patients completely halted their local treatment.
Over 60% stopping treatment for a chronic architectural skin condition is just a massive failure of medical communication.
It really is.
And when you dig into the survey responses regarding why they stopped, it's basically driven by an intense fear of harming the baby.
Which is so common.
And on a human level, it's entirely understandable. I mean, you are holding a highly potent prescription steroid ointment, you're reading a generic warning label, and your instinct is just to protect the fetus at all costs.
Of course.
But the truly shocking part of the Schaffer study is that 17% of these patients were advised directly by their prescribing doctors to stop treating their LS during pregnancy.
Yes. And that advice stands in direct opposition to the established medical consensus across basically every major dermatological and gynecological body.
Literally all of them.
Right. The BID guidelines, the BIH guidelines, the clinical protocols from the Women's Health Clinic, and the Lindgren Review, they all universally conclude that topical steroids, even ultra-potent formulations like clobetasol, are completely safe for use during both pregnancy and breastfeeding.
Okay, we really need to explain the physiological math on why it's safe. Like, let's banish the fear by explaining the actual mechanics of absorption.
Absolutely. It comes down to the volume of systemic absorption versus localized action.
Okay.
When you apply a topical steroid for VLS, the application is restricted to a highly targeted, localized area.
Right. It's not like you're covering your whole body.
Exactly.
Oh.
The total body surface area for this specific application is less than 2%.
2%.
Right. So using a pea-sized amount, typically applied just 1 to 3 times a week for maintenance, that means the active ingredient binds to the local tissue receptors to halt inflammation right there.
Just at the site.
Yeah, the trace amount of medication that actually crosses into the bloodstream and becomes systemic is incredibly minimal. It falls well below any threshold that could impact fetal development.
Okay, but if the pregnancy hormones are acting as that biological pause button we discussed earlier, and the patient is in that 44% who feel great with 0 itch,
Right.
why apply the steroid at all? I mean, if the symptom is gone, putting a strong medication on the skin just seems totally unnecessary.
And that's exactly what a lot of people think. But the danger lies in equating the absence of itch with the absence of disease activity.
Oh, wow.
Because LS is fundamentally a disease of tissue architecture, not just a surface irritation.
Okay, architecture.
Right. While the sensory symptom of itching might be completely suppressed by the pregnancy hormones, the underlying low-grade inflammatory process can still be silently altering the cellular structure of the tissue.
So it's still doing damage.
Yes. This results in the gradual loss of elasticity, microscopic scarring, introital narrowing, and clitoral fusion.
So the silent structural damage continues even when the fire alarm isn't ringing.
Precisely. Now consider the extreme mechanical demands placed on that specific tissue during a vaginal delivery.
Right, it's intense.
Very. The tissue must stretch to an extraordinary degree To accommodate that sheer physical force, the mucosal tissue must remain highly pliable and elastic.
Makes sense.
If a patient drops their steroid maintenance because they aren't itchy, the skin slowly becomes rigid, fibrotic, and fragile at a cellular level.
So it basically just loses its stretch.
Exactly. Dropping the medication essentially guarantees a much harder delivery and significantly more severe tearing because the tissue simply lacks the structural integrity to stretch.
Wow. It is basically like strength training the tissue.
That's a good analogy.
I mean, you wouldn't attempt to run a marathon without conditioning your muscles for months beforehand.
Right.
You cannot ask compromised skin to stretch for childbirth without continuously conditioning it with the prescribed medication to maintain that elasticity.
You really can't.
So, assuming the tissue is conditioned, let's look at the main event, childbirth. Let's deliver the definitive answer from the data right now. Having VLS does not inherently rule out a vaginal delivery.
It does not. The clinical outcomes are incredibly reassuring on this front. The OYEN review, analyzing 33 pregnancies, documented that an overwhelming 82% of those patients had spontaneous vaginal births.
82%.
Yeah, and the much larger Schaffer study of 206 pregnancies reinforced this. They showed 59% had spontaneous vaginal birth, with 23% undergoing planned C-sections.
No, it is vital to contextualize those C-sections, though.
Yes.
Because in the Schaffer study, the VLS diagnosis influenced only 10% of those surgical decisions.
All right, so a very small fraction.
Exactly. The vast majority of those C-sections were performed for standard obstetric reasons completely unrelated to the patient's skin condition. But we do have to address the tearing.
We do.
Fragile skin stretching to its absolute limit. What is the clinical reality of the damage?
Well, the Schaffer study categorized the outcomes really clearly. 71% of the patients who delivered vaginally reported what the medical community classifies as normal, expected tearing for childbirth.
Okay, so normal tearing.
Right. About 12% reported significant perineal tearing, meaning the tear extended into or through the anal sphincter muscle.
So tearing is a statistical reality of childbirth regardless of LS, but the medical literature outlines specific strategies to minimize the severity of that trauma, right? Like perineal massage is heavily emphasized as a mechanical intervention.
It is. Starting around 34 weeks of gestation, the practice involves manually massaging and stretching the perineum.
Okay.
This physical manipulation increases blood flow and mechanically encourages the flexibility of the tissue fibers. It's a direct, physical way to enhance the elasticity we were just discussing.
Like physical therapy.
Exactly, functioning as a localized physical therapy to reduce the resistance of the tissue during crowning.
Now, I spotted a fascinating clinical contradiction in our sources regarding the actual moment of delivery, and I really want to parse the logic behind it with you.
Oh, the episiotomy recommendations.
Yes. The 2018 BAD guidelines strongly suggest that a patient with LS should have a controlled delivery involving an early episiotomy to prevent severe jagged tearing.
Right.
However, the more recent 2023 Schaefer study explicitly advises avoiding episiotomies whenever possible.
Yeah, it's a big shift.
If I'm interpreting the underlying medical logic correctly, this discrepancy basically comes down to a surgical incision on healthy, pliable skin versus a jagged tear through rigid, compromised skin. Am I getting that right?
You are hitting on the absolute core of why personalized medicine is essential here. The different guidelines actually reflect two different patient profiles based entirely on disease control.
Okay, explain that.
An episiotomy is a clean, straight surgical cut. If a patient arrives in the delivery room with poorly controlled LS, meaning they abandon their steroids and their tissue is heavily scarred, fused, and entirely rigid, a clean surgical cut is medically preferable. It will heal significantly better than a jagged, explosive, multidirectional tear through unyielding fibrotic tissue.
But if the patient has maintained their steroid use, conditioned the tissue, and retained that vital elasticity, the medical calculus flips.
Completely. If the tissue is healthy and pliable, avoiding surgical cuts is the optimal path. The primary goal is always to maintain intact tissue whenever biologically possible.
Right.
So the Schaffer study's recommendation to avoid episiotomies assumes the patient has been properly managed and compliant with their topical therapies throughout the entire pregnancy.
That distinction puts immense power back into the patient's hands during those 9 months.
It really does.
So the delivery is over, you survive the main event, you would naturally think the highest risk portion of the journey is complete.
You would think so.
But here's where it gets really interesting and honestly deeply challenging. Once the baby is delivered, the combination of immense physical trauma to the tissue and the sudden drastic drop in pregnancy hormones triggers the most vulnerable phase for an LS patient,
Yes.
the postpartum period.
The biological pause button we discussed is abruptly released. The protective flood of estrogen and progesterone crashes right back to baseline levels.
Wow.
And simultaneously, the vulvar tissue has just sustained significant physical trauma, whether from extreme stretching, natural tearing, or a surgical episiotomy.
And that physical trauma introduces a documented mechanism mentioned in the BID guidelines known as the Koebner phenomenon.
Yes, the Koebner phenomenon.
If I understand the mechanics of this correctly, the trauma of the birth essentially acts as a localized magnet for a new disease flare.
Exactly.
The immune system rushes in to heal the obstetric tear, but because the immune system is basically faulty in an LS patient, it brings the destructive autoimmune inflammation right to the site of the wound.
That is the exact mechanism. The Koebner phenomenon demonstrates how a systemic autoimmune condition can be localized and triggered by physical injury.
Right.
The cytokines and inflammatory cells rush to the episiotomy scar or the perineal tear to initiate tissue repair. But in VLS, that inflammatory response is dysregulated.
So the healing itself is the problem.
Yes, the healing process itself becomes the epicenter of a new, highly aggressive LS flare. The disease literally colonizes the fresh wound.
Which perfectly explains the massive symptom rebound documented in the data. I mean, the Schaffer survey reveals that 60% of patients report a gradual, intense increase in LS symptoms postpartum.
60%?
Yeah. The severe itch and burning come roaring back at the exact moment they are trying to heal from obstetric wounds.
It's awful.
And when we look at the Nguyen data on medication compliance during this critical window, the numbers just fall apart. Patients were 76% compliant with their steroids during pregnancy, but that compliance plummeted to 60% postpartum.
And if we connect this to the bigger picture, this steep drop in compliance exposes a profound systemic failure in how we handle postpartum care.
Yeah, completely.
The medical infrastructure overwhelmingly shifts its focus to the neonate, leaving the mother to navigate her own recovery basically in a vacuum. For a patient managing VLS, this systemic blind spot is an active threat to their long-term tissue health.
Well, and we have to acknowledge the very raw human element driving that 60% compliance drop. Patients aren't abandoning their medication because they suddenly lack discipline.
No, not at all.
They are operating under the crushing weight of parent brain. It's the reality of severe sleep deprivation, navigating a newborn's feeding schedule, postpartum bleeding, and just pure physiological survival mode.
Absolutely.
Remembering to meticulously apply a specific ointment to a highly painful, torn anatomical area naturally falls off the radar. Planning for your LS care postpartum requires as much, if not more, logistical preparation than packing your hospital bag.
It really does.
It requires setting up a visible station in the bathroom and, enlisting a partner to track medication days.
Because maintaining consistent steroid application on those healing obstetric tears is biologically non-negotiable.
Right.
It is the sole mechanism available to prevent aggressive, permanent architectural scarring during the tissue repair process.
So you have to do it.
Yes. As the tissue knits itself back together, if you do not actively suppress the local autoimmune inflammation with the steroid, the body will basically replace healthy mucosal tissue with rigid, fused scar tissue.
And the toll this takes extends far beyond the physical architecture of the skin. When you combine the intense return of the itching, the acute physical pain of healing tears, the relentless demands of a newborn, and the sheer mental exhaustion, the psychological data makes complete sense.
Yeah, it's very stark.
The Schaffer study found that postpartum depression rates in this specific patient group sit at 28%. That is double the international average of 14%.
It represents a perfect storm of compounding stressors. The chronic physical discomfort combined with the deep isolation of navigating a condition that 92% of providers cannot adequately advise on. It creates a profound, measurable psychological burden on the patient.
Okay, let's distill all of this complex data into clear takeaways for you, the listener. Does childbirth worsen vulvar lichen sclerosus?
The evidence tells us no, not inherently.
Right. If the disease is consistently controlled, if you maintain your safe topical steroid treatments to condition the tissue and preserve elasticity, and if you utilize physical strategies like perineal massage, you can deliver and heal just as well as anyone else.
Exactly.
The true danger is not a mechanical act of childbirth. The danger lies in the lack of medical education, the unfounded fear of safe maintenance medications, and the critical postpartum drop in self-care.
Medical knowledge and proactive preparation are your most effective protective factors. Sustaining compliance with maintenance therapy is the biological key to protecting the tissue architecture, minimizing severe tearing, and ensuring a smoother postpartum recovery, free from aggressive Koebner-induced scarring.
Which leads me to a final, slightly provocative thought for you to mull over as we wrap up today.
Oh, curious.
We've spent a lot of time today analyzing the physical trauma of childbirth triggering LS through the Koebner phenomenon.
Right.
We know physical wounds summon the disease process to the surface, but what about the role of severe psychological trauma?
Investigating the mind-body connection, specifically regarding how the nervous system modulates autoimmune responses, is really the next crucial frontier for this condition.
Because we know that autoimmune diseases are heavily influenced by the autonomic nervous system.
Right. The fight-or-flight response.
Exactly. Surges of cortisol, chronic stress, and a sustained fight-or-flight response actively dismantle immune regulation. Given that 50% of pregnant VLS patients report severe delivery-related anxiety and they're navigating an exhausting, isolating medical system, could that immense emotional stress actually act as a primary trigger for these postpartum LS flares, entirely independent of the physical tearing?
That's a huge question.
I mean, if you are terrified, unsupported, and deeply anxious for 9 months, your nervous system is in overdrive. It begs the question, maybe the postpartum flare isn't solely about the physical scar tissue. Maybe it's the physical manifestation of sustained medical trauma and anxiety.
It is a highly credible physiological hypothesis. The interconnected nature of stress hormones and autoimmune inflammation underscores exactly why comprehensive VLS care cannot just be a prescription tube.
It has to be more.
It must include proactive education and psychological support to really downregulate the nervous system.
Well said. Thank you for being here with us on this deep dive. And thank you to you listening for taking the time to get well informed. Because when that path gets dark and feels shrouded in silence, knowledge is your flashlight.
It really is.
It's the absolute best defense against medical anxiety. Take care of yourselves, condition that tissue, and we'll see you next time.